Greetings, I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's November 2019 issue. There are 3 articles that have been selected as our Editor's Choice or Highlight articles this month. Our Editor's Choice is a review article entitled Patient-Reported Outcomes Have Arrived, a practical overview for clinicians in using patient-reported outcomes in oncology. This article is authored by Dr. Rama Osami from the Department of Medicine at Mayo Clinic in Rochester, Minnesota, and Dr. Anita D'Souza from the Department of Medicine at the Medical College of Wisconsin in Milwaukee. Patient-reported outcomes are health-related assessment and feedback that are provided directly by the patient, optimally via standardized and validated tools, and are done so without the aid of an intermediary. As such, patient-reported outcomes may reflect the voice of the patient that may be truer, as it is not susceptible to what may be lost in translation. Patient-reported outcomes are increasingly and appropriately emphasized in current paradigms governing the practice of medicine that are founded on patient-centric care and shared decision-making. Patient-reported outcomes are relevant to and may benefit not only patient care, but also healthcare policy, medical research, and the search for more effective therapies. In the current issue of Mayo Clinic Proceedings, Osami and D'Souza provide a scholarly and comprehensive overview of patient-reported outcomes that both outlines the key broad concepts in the field and delineates the specifics and granularity of patient-reported outcomes as they pertain to the subspecialty of oncology. The authors begin with a perspective regarding the development, purpose, and current definition of patient-reported outcomes, and how these outcomes increasingly ramify into diverse fields and disciplines, the latter consideration underscored throughout the review. Osami and D'Souza discuss how patient-reported outcomes aid in processes that secure approval by the FDA of new drugs and labeling claims, in the course of which they provide a compelling example of labeling claims in which these outcomes provided the basis for oncologic therapy, namely ruxolitinib for constitutional symptoms in myelofibrosis. They also enumerate specific circumstances wherein patient-reported outcomes may be especially helpful. The authors discuss how patient-reported outcomes complement traditional endpoints in clinical trials in oncology by assessing functional status and quality of life, among other patient-relevant considerations. How patient-reported outcomes aid in patient stratification in clinical trials, as in several types of cancers, patient-reported outcomes can prognosticate on patient survival, and how patient-reported outcomes contribute to the assessment of drug toxicity. These conditions then lead into the contributions of patient-reported outcomes in comparative effectiveness research and databases in oncology. This informative and timely review culminates in illustrating the contribution of patient-reported outcomes to patient-provider communication and other aspects of clinical oncologic care, and in delineating the existing challenges in realizing the full potential of patient-reported outcomes in oncologic practice. Our first highlight article is an original article entitled Association of Fitness and Grip Strength with Heart Failure, Findings from the UK Biobank Population-Based Study. This article is authored by Dr. Anne Sellers and colleagues from the University of Glasgow and the Robertson Centre for Biostatistics, both in Glasgow, United Kingdom. Cardiorespiratory fitness is both a biomarker and a determinant of health. Higher levels of cardiorespiratory fitness predict less all-cause mortality and mortality caused by cardiovascular disease, and a diminished risk for hypertension, the metabolic syndrome, and stroke. Indeed, the benefits of cardiorespiratory fitness may go beyond conditions linked to cardiovascular disease and may extend to disparate diseases such as cancer, inflammatory bowel disease, depression, and dementia. In the present issue of Mayo Clinic Proceedings, Sellers et al. Examine the association of cardiorespiratory fitness and heart failure using the UK Biobank. The United Kingdom Biobank is a vast repository of epidemiologic, clinical and laboratory data collected on approximately 500,000 subjects in the United Kingdom between the years 2006 to 2010, with the aim of ascertaining the risks for and the course and consequence of assorted diseases. Sellers et al. Selected in the analysis patients who were without comorbidities at baseline and were event-free after 2 years. And in more than 57,000 such patients with cardiorespiratory fitness data, they demonstrated that increased cardiorespiratory fitness was associated with a decreased risk for heart failure. Indeed, an increase of 1 MET in cardiorespiratory fitness was accompanied by an 18% decrease in the risk for heart failure. Cardiorespiratory fitness as measured in the United Kingdom Biobank required graded exercise testing and the calculation of oxygen consumption. Sellers et al. Thus questioned whether a simpler, easier to assess index of muscular integrity and functionality would also associate with heart failure. The authors utilized grip strength, as grip strength, when increased, like cardiorespiratory fitness, predicts reduced all-cause mortality. Grip strength data were available in approximately 375,000 subjects without comorbidities at baseline and who remained event-free after 2 years. In these subjects, grip strength was associated with a lower risk for heart failure, with each 5 kilogram increase in grip strength accompanied by 19% reduction in the risk for heart failure. In discussing their findings, Sellers et al. Make a number of important points. First, as compared with data in the literature, the present findings of Sellers et al. Would suggest that risk factors such as cardiorespiratory fitness and grip strength may have a greater effect on the propensity for heart failure as compared with genetic determinants. The former two indices are modifiable, whereas the latter is not. Second, their study involved a general population without comorbidities at baseline, and thus their findings indicate the predictive potential of cardiorespiratory fitness and grip strength in forecasting the risk of heart failure developing de novo. Third, because of its simplicity and ease of measurement of grip strength, the latter may be considered as an office-based screening tool for patients in assessing their relative risk of developing heart failure. Our second highlight article is an original article entitled Evidence of Diagnostic and Treatment Delay in Seronegative Rheumatoid Arthritis, Missing the Window of Opportunity. This article is authored by Dr. Catherine Coffey and colleagues from the College of Medicine and Science at Mayo Clinic in Rochester, Minnesota. The search for novel biomarkers that can disclose diseases before conventional biomarkers can is ongoing in virtually all disciplines of medicine. Such biomarkers offer improved specificity and sensitivity in diagnosing disease and may point to specific therapeutic strategies and/or the timing for the initiation of such strategies, all of which may improve patient outcomes. For example, this search in patients with acute myocardial injury led to troponins, while in acute kidney injury a number of biomarkers are now recognized as more sensitive than serum creatinine and are under consideration for their prognostic and therapeutic significance. This need for biomarkers may be especially relevant for diseases that are facsimiles of others but lack serologic biomarkers possessed by these other diseases. Germane to this consideration is a study by Coffey et al. In the current issue of Mayo Clinic Proceedings that examined outcomes in two forms of rheumatoid arthritis, the more common type that's seropositive for rheumatoid factor and/or anti-citrulline peptide antibody, and the less common type that is seronegative for these two biomarkers. Diagnostic criteria for rheumatoid arthritis in this study by Coffey et al. Involved the 1987 American Rheumatism Association criteria and the 2010 American College of Rheumatology and European League Against Rheumatism criteria, the 2010 scoring system more broadly emphasizing earlier more acute manifestation of rheumatoid arthritis and the presence of serologic factors. In this study involving 214 patients who fulfilled both the 1987 and the 2010 criteria, 145 were seropositive and 69 were seronegative. In patients with seronegative rheumatoid arthritis as compared with seropositive rheumatoid arthritis, the time periods were all markedly longer from first joint swelling to the achievement of the 1987 and 2010 classification criteria and to a clinical diagnosis of rheumatoid arthritis, and from the first joint swelling to commencing disease-modifying anti-rheumatic drug therapy. Remission rates in patients with seronegative rheumatoid arthritis were substantially less than those in patients with seropositive rheumatoid arthritis when the complete Boolean definition of remission was utilized. It is perhaps not surprising that this delay in initiating treatment in seronegative rheumatoid arthritis was attended by diminished rates of remission, as the evidence is quite clear that the efficacy of disease-modifying anti-rheumatic drug therapy necessitates expeditious initiation within a certain time frame in the course of the disease. While this study did not address the basis for this delay in initiating therapy in the seronegative patients, Coffey et al. Suggests that this may originate from the greater diagnostic challenges in this seronegative subset of patients. Interestingly, a certain percentage of seronegative rheumatoid arthritis patients may seroconvert, but at a later time point in the course of the disease, and one at which disease-modifying anti-rheumatic drug therapy may not be effective. These novel findings by Coffey et al. Should stimulate the search for serum biomarkers for rheumatoid arthritis detectable in patients presenting with features of rheumatoid arthritis but lacking the presence in serum of a rheumatoid factor and/or anti-citrullinated peptide antibody. You can access these highlights and editor's choice articles free of charge during the entire month of November. When you visit our updated Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page as well as through iTunes. You'll also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you'll see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our home page is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.